Thanks, Dr. Alamy, and thanks to you all for attending this talk. So today I'm going to be talking about health at every size. There we go. I have no financial conflicts of interest. My views are mine alone and not those of the VA where I work. What I would say is my intellectual conflicts of interest related to this talk would be that health at every size, the acronym for that is HAES. That's commonly used. I would say I'm HAES friendly, but not exclusive to that. I prescribe weight loss medications, referred people to weight management clinics and things like this many times. But I'm also feel fully capable and able to identify the situations where I would prefer a HAES approach to care. So I want to start with that caveat. I'm a primary care doctor, so my framing of weight in general might be different from that in a specialty clinic, like in a weight management clinic or something like this. So my clinical practice is purely in primary care. You may know that the USPSTF has recommendations on weight loss interventions. These are now from 2018. They are in the midst of a new release of these guidelines, probably next year. It's called Behavioral Weight Loss Interventions to Reduce Morbidity and Mortality. And it basically starts with someone's BMI and says if your BMI is above 30, the clinician you see should be recommending to you to be referred to a comprehensive lifestyle intervention program for the intent of weight loss to reduce morbidity and mortality. And if you have a BMI in the 25 to 30 range, if you have comorbidities, we should be referring patients like this to those clinics as well, or to those lifestyle programs. I would just point out this also tends to match the FDA label indications for the newer anti-obesity medications, basically either in the overweight classification of a BMI with comorbidities or a BMI above 30. And so if you looked at prevalence of obesity nationally, that would be referring more than half the US population to these programs, i.e. like having this conversation all the time in clinic. I would call this the weight-centric or weight normative approach to care of patients with high body weight or BMI. And what I wasn't personally taught about in med school, but is an alternative approach that I think every clinician should be aware of and know of the principles of it and be capable of employing those when they see fit, is the health at every size approach, or HAES. This is promoted by the Association of Size, Diversity, and Health. And there's three core principles within HAES. One is weight inclusivity, to reject the pathologizing of specific weights as inherently unhealthy. Number two would be intuitive eating, which aims to, instead of having a nutritional program that's focused on weight control, to instead promote flexible and individualized eating plans based on hunger, satiety, and nutritional needs to pursue a balanced diet without the intent for weight loss, in other words. And enjoyable activity, to help someone of any size, ability, or interest to find an activity program that's enjoyable to them and sustainable. I would call this a weight neutral or inclusive approach to care. I would add one thing that is not explicitly called out within the HAES, as a trademarked approach to care, but is commonly used, I think, more generally to speak about weight neutral approaches to care. That's not specifically called out by them, but is something that I think is highly related to this, is to practice with trauma-informed care as it relates to weight. And I'll talk a little bit about that in a bit. But just to give a little bit of background, these conversations come up, or can come up, all the time, because high BMI is extremely common in the US. 42% of US adults, according to CDC data in 2020, had a BMI above 30, 9% above 40, 30% in the overweight BMI classification by WHO, which leads to almost 3/4 of adults who have a BMI that would, be colored red or abnormal, depending on your health system on the EHR. And I like to point out while elevated BMI is increasingly prevalent, We're also in the midst of a dieting epidemic, and cold call surveys of US adults, where someone asked them on a survey questionnaire, are you currently or have you been trying to lose weight in the past 12 months? The percentage of people who would respond yes to that has steadily increased over the last century. And 67% of US adults, if it's filtered to those with high BMI, would say yes in the past year. And 97% of adults with high BMI would say they had ever had a concerted attempt at a lifestyle intervention for weight loss as an adult. So dieting is extraordinarily common. And why do people get so frustrated by diet? I think you've probably had lectures in med school and CME and other settings about our modern food environment and how it promotes adiposity, and also our activity milieu. We have technology that makes it easier to take less steps each day and things like this. That promotes high rates of obesity. But I think it's important for everyone to understand that body weight is regulated. There are homeostatic forces that the body uses to control body weight, regardless of an adult's baseline levels of adiposity. There's two hormones, leptin and insulin, that are called adiposity negative feedback signals, and they rise and fall in accordance with fat stores and actin circuitry in the brain that controls both the desire to eat more and baseline energy expenditure, both resting energy expenditure and non-exercise activities such as posture, fidgeting, which are things that can account for up to a third of daily calories. The body can turn down the amount of fidgeting someone on a weight loss diet is doing to try to restore body weight to what it thinks it should be. And so, the outputs of that system, one of them is a concept of metabolic adaptation, where someone's daily energy expenditure will rise and fall out of proportion to their change in weight. So when someone loses weight, the amount of energy their body expends to keep them alive each day expectedly goes down, because it's less overall body weight that's being managed or turned on by the energy systems. But the body has ways through this circuitry to turn down the amount of energy we expend, even beyond what would be expected by that weight change alone, by several hundred calories in either direction, depending on whether it's a period of weight gain or weight loss. That's called metabolic adaptation. A concept within that as well is, you might say, well, if someone has enough exercise, they might be able to overcome that that system and burn more calories than their body's trying to turn down. I.e., there's an additive approach to that. You have your baseline amount that your body burns. If you increase your exercise, you could overcome it. And that's true to a small extent, but in fact, the body has ways of turning down or resting energy rates even more. That's called constrained energy expenditure. So you might be exercising more, but in the parts of the day you're not exercising, your body's moving less, fidgeting less, all these things. So our bodies are pretty smart at trying to keep it at the weight that it thinks that we should be at once it's at a stable weight as an adult. So that's the energy side of things. On the hunger side of things, we know that these hormones, leptin, amylin, ghrelin, and a host of other hormones in the body that are responsible either for satiety, feelings of fullness, or hunger, change as during weight loss. For instance, there's a study 2011 where people went on a very low calorie diet for 10 weeks and then were followed for a year after that. And there was about a 12% body weight loss at 10 weeks, regain of more than half that weight by a year later. And they measured the levels of different hormones that the body has that control these things. And basically the hunger hormones are increased, the satiety hormones are decreased even a year later, as after a period of a lot of weight regain, and fasting hunger has gone up as well. And so if you look at weight loss, both weight loss and weight loss with exercise trials, you tend to see a pattern that weight loss might be most effective in these dietary interventions around 6 months, and then weight regain is the consistent trend by a year. And the trials that extend beyond that, that measure weight loss beyond 12 months, show more and more weight regain over time as these systems that the body has to try to control body weight continue to attempt to restore body weight to what they think it should be. And that's independent of what kind of like macronutrient profile that that's part of the dietary intervention, whether it's like a low carb or reducing calories in every, carbs, protein, fat, or a low fat diet. A lot of these have a control group called dietary advice, and that's us as clinicians in a visit telling a patient, I think you should lose weight. I think you weigh this. I think you should weigh closer to this. That's not effective counseling. I'm going to talk in a bit about the harms of that approach beyond just the fact that it's not effective for weight loss. And I don't recommend doing that. So I would just like to make the case that diets and exercise fail primarily because our bodies regulate body weight through mechanisms such as hunger signaling, metabolic adaptation, and energy constraint, and not because of things like people with high BMIs are lazy or lack concern for their health or lack motivation or willpower or something like this. I think that's a false narrative and needs to be rejected. So in our paradigm, where we're commonly taught in training this weight-centric approach to care, where basically we should be telling over half of our patients that they need to be part of a lifestyle intervention program. And I think the trend more recently with this, with the growing availability of weight loss medications, is to have those conversations about weight loss meds. One of the results of this, at least for the lifestyle interventions that aren't actually effective for most adults in those trials, is when we have these guidelines that we're taught about that lifestyle interventions should be a first-line approach for weight loss, and yet they're not effective for most people because body weight's regulated. That disconnect that exists promotes the belief, I think, for clinicians that obesity is a choice. It's a lifestyle factor that's within someone's control to change. And I think the common result to patients is that they become the recipients of weight discrimination in healthcare settings, which can lead to harms to their health, such as a concept of weight bias internalization that I'll talk about a little bit. So weight bias, sort of like any kind of bias, has different overlapping components to it. One would be both implicit and explicit stereotypes. And those might be things like beliefs clinicians or the general public might have towards someone of an abnormal body weight, that they're lazy or not smart or unsuccessful or undisciplined, dishonest, unintelligent, non-compliant, et cetera, whether that's an explicit stereotype they hold, that this is something that is said out loud, that's recorded, in clinical documentation or something like this, or implicit, where the stereotypes are kept and might not even be something within your consciousness, but have impacts on the way you approach patients with a high BMI, carries harms. There's the negative attitudes that can come with those stereotypes of, for instance, not wanting to befriend people with a high body weight or sit next to people like that, or be inclined to take an empathetic approach to care, for instance, in healthcare settings for patients with high body weights. And then there's discrimination, where there's unfair, unequal treatment to those with high body weights. And so I'll unpack this a little bit more here. And in survey studies of patients where they're asked, those with a high body weight, have you experienced weight discrimination, and who from? We're second only, physicians are second only to family members as the most common perpetuators of ever or more than once episodes of weight discrimination for patients. And there's other health professionals on this list as well. There is, in other survey data where clinicians respond to statements about potential stereotypes or attitudes towards patients with obesity or a high BMI. Statements in one survey, this was of 5,000 primary care physicians, where the statement was most obese patients could reach a normal weight for height if they're motivated to do so. Obesity is due to lack of willpower. A substantial minority agree with statements like this. Some other components on this that weren't listed here, 50.8% agreed that patients with obesity were non-compliant, 44% that they were weak-willed, 30% that they were, quote, lazy. So these stereotypes are quite prevalent. There's an interesting weight bias scoring scale. It's done by Project Implicit. Anyone can do this. It only takes a few minutes. If you Google Project Implicit weight bias, it walks you through. And it tries to measure someone's implicit or explicit bias in different categories. And for this, it would be weight bias. There was a study of clinicians, of physicians, I should say, who filled out these surveys, and they self-reported their own BMI, regardless of the clinician's BMI. Their implicit and explicit weight bias effect was either large or medium, so a significant amount of weight bias against patients with a high BMI. And then studies that have watched clinicians in observations of clinical visits and tried to score the way that they are carrying on conversations with patients with of different BMIs. In one domain that was scored in this study would be emotional rapport building, with subdomains like empathy, concern, reassurance, and partnership. An example, empathy statement being, I can see how frustrated you are by your slow progress. Anyone would be. The rates of emotional rapport building were substantially lower with those with a high BMI. This was a study of primary care physicians. So the result, I hope I've made the case here that it is quite common weight bias in clinical settings, that clinicians carry weight bias, and that patients may experience that weight bias as and one of the results of repeated exposure to bias, regardless of what type of bias it is, whether it's racial bias, gender bias, or in this case weight bias, is it puts individuals at risk over the course of their lives for bias internalization, where the negative stereotypes and beliefs associated with that bias can become internalized. Patients start believing some of those negative stereotypes or concepts that are associated with that bias, and have adverse outcomes for their health. So there's a scale called the weight bias internalization scale that has statements like, because of my weight, I feel just as competent as anyone. I hate myself for my weight. My weight is a major way that I judge my value as a person. Individuals with a high BMI or BMI above 30, obesity by WHO standards, a substantial number of patients like this would have a very high score on this WBIS and bias internalization scale. And what's the impact of that? There's been other studies that have looked at people with high BMI that have these high bias internalization scales, and there's strong associations with poor health outcomes. This stigma can decrease healthy behaviors. It's associated with decreased physical activity when individuals have the experience or belief of themselves of low self-efficacy, is associated with decreased physical activity, increased associations with binge eating and other eating disorders, and worsened mental health outcomes with increased risk factors for depression and suicidality, risk factors for having low self-esteem, regardless of other demographic variables. That tends to be true. And then discrimination can worsen the social determinants of health. In other words, the settings outside of healthcare that can drive someone's ability to achieve optimal health for them, such as finding gainful employment that is enjoyable to them, experiencing a fair hiring and promotion process in the workplace, having the right educational opportunities, All of these things can the weight discrimination in settings outside of healthcare can worsen the social determinants of health that are associated with overall worsened health outcomes. In healthcare settings, there is a circular pattern that can occur where someone with obesity at baseline, because of weight discrimination in healthcare settings, can be the victim of substandard healthcare. There's been studies that have shown repeatedly that providers in visits with patients with high BMI tend to carry those visits at a shorter time interval, have less general health education counseling with those patients, misperceive their motivation as measured in the way that they document and chart about those patients. And patients with high BMI are less likely to experience age-appropriate cancer screening. And these substandard healthcare experiences and poor experiences in general healthcare settings are strongly associated with healthcare avoidance. Patients with high BMI are more likely to cancel visits and more likely to delay evaluation of concerning health symptoms because they are perceiving in those settings that that everything is being blamed on their obesity. Someone coming in with flank pain with a high BMI, where the clinician's first impulse is to counsel them on their excess body weight and how to lessen that instead of undergoing an appropriate evaluation for that pain, for instance. The disrespectful treatments that they receive, the unsolicited advice at every turn to lose weight, and the healthcare setting itself of having equipment and office spaces that doesn't fit them, that repeatedly sends the message that you are not welcome here. So how can we make the experience of healthcare better for patients regardless of their shape or size? I think it's important to employ in this domain trauma-informed care. Some of you may be familiar with that concept as it relates to other patient populations, such as those who have been the victims of sexual or emotional or physical abuse of some type in their childhood or adult lives. But the general principle, I think, stands here, which is to make the assumption for all your patients that it's more likely than not that they've experienced substantial adverse events in their life and trauma that directly impacts the way that they are able to interact with the healthcare system and their experience in managing their health. That we should carry that as an assumption in the way that we approach care. And so I would just encourage you to imagine, for instance, you're a patient sitting in this doctor's office here. You're about to have an appointment with a new provider that you don't know, that you scheduled online. You've never seen this provider before. Your BMI is 45. You're quite concerned about your shoulder pain and hope that is going to be discussed in this visit. You've had in the last several visits for things completely unrelated to weight, unsolicited conversations about diet and exercise, which have been things that you have made concerted efforts on numerous times in your adult life to no avail. Your insurance does not cover weight loss medications, and that's not affordable to you. And also you are rightly reluctant to pursue weight management surgeries, but nonetheless, your priority for today's visit is to explore your shoulder pain. And as you hear the knock on the doctor's door there when they're opening, the fear that might be there, that this is going to be another one of those conversations where weight will be at the forefront, whether you want it to or not. What is the way that we can, as clinicians, approach this patient with compassion and kindness and provide the effective care that they deserve? I think we should all be capable of doing this. One thing I would say that's important here, besides just recognizing, as we were just discussing, that it is more likely than not that our patients of body sizes that are not within our acceptable cultural norms have received weight bias and stigma and discrimination in healthcare settings. That recognition is the important first step. And another important step is to avoid the re-traumatization. There's things in our healthcare setting that might be beyond our individual control as clinicians working in a clinic. For instance, having a scale that's in a public facing area in the lobby where a patient's weight and height are directly visible to anyone passing through that space, that we should try to avoid publicizing to others someone's weight in that way, and ask permission to those patients on whether it would be okay with them that we could measure their weight. Won't get into the controversies about whether we should be measuring weight routinely at all in primary care settings, but at the very least that the patient is given the power to decline taking a weight, particularly when it's in a public setting like this. We know that patients with larger arm sizes, if their blood pressure is taken with a standard blood pressure measurement, there's a study in JAMA-IN 3 years ago that looked at this. It can overestimate their blood pressure by 10 to 15 points. So we should have appropriately sized blood pressure cups of all types available in clinic settings. And if they're not available, helping a patient through whatever means is possible through the healthcare setting and their insurance to find a blood pressure machine for their home measurements that fits them adequately. And things like having chairs that fit people of different size bodies and shapes. These are things in the healthcare setting that can avoid the experience of re-traumatization for individuals with high body weight. And then another thing would be the language that we employ and use with patients, regardless of their shape and size, but particularly of those outside our cultural norms of what's considered to be a normal or acceptable body weight. I find I'm often in the position where I'm hoping to pivot away from a discussion about weight, either because the patient's expecting that that's something I'm going to immediately bring up and preempt the discussion by bringing it up themselves, or it's, it has long been a priority for them, and they're hoping that be a discussion, or every clinician in the last several visits has brought it up, so they assume that just has to be a discussion. Besides, if any discussion about weight is to occur, besides the general principle I always employ, which is to ask permission to have that discussion, I'm also trying to find language to help pivot away from those discussions when I instead want to talk about someone's shoulder pain and not their body weight, because I think that's the most relevant thing to their health today and would like to discuss that, seeing as that was their top concern as well. So there's language I like to use sometimes, particularly if a patient's been frustrated by their lack of success with diet and exercise programs. Something like, your body may like the weight that you are at. Just to allude to, I understand as your doctor that it is not something that reflects on your self-control, that you're having trouble losing weight because of the lack of success from diet and exercise. I know that body weight is regulated. There's a strong scientific background that validates that belief. And then I might use statements to try to pivot to other ways to help someone improve their health. I think you can be healthy without losing weight. And we'll talk about some weight neutral treatment approaches here in a moment. I think we can focus on other ways to improve your health. There is a movement currently to reclaim the word fat as a positive adjective, or a neutral adjective, I should say, for individuals with a high body weight. And I understand that that's a movement occurring right now. I would say, though, consistently in survey data of patients, there's a strong preference against using the terms fat and overweight when talking, in whatever context you might be doing so, talking about someone's weight. Patients tend to prefer discussing weight in terms of things such as BMI or having a higher weight or something like this. So those are kind of some general counseling approaches that, or turns of phrase, I guess I should say, that I'm often using in these situations. So I'd like to turn now to talk about a bit about weight neutral treatment strategies for patients, regardless of their body shape and size. And I'm going to go through a number of common clinical conditions and just present some evidence related to them. But my suspicion is that we all already know how to employ these weight neutral treatment strategies because we do it all the time. And the setting we do it all the time is when individuals without obesity have these conditions. So that thought experiment of how would I approach this condition in a patient without obesity is the place to start there. And I believe, I'm certain everyone on this call and elsewhere that are practicing internists would be capable of doing so. So some of the general principles that are true regardless of someone's weight or body shape or size, that I'm trying to promote in primary care is finding ways to explore a balanced diet without a specific intent for weight management, reducing added sugars in the diet, reducing the total servings per week of red meats, processed foods, things like this. Couching that though, and knowing that a patient, for instance, of disadvantaged socioeconomic circumstances would have more trouble making many of those changes. So trying to take a patient-centered approach there, counseling patients on healthy sleep patterns, sleep hygiene, CBT for insomnia and so forth, addressing mental health as pertinent and substance use, and finding with a patient an enjoyable activity program that's feasible to them, regardless of their physical abilities, body shape, or size. These are general principles that we should be employing with patients of any weight, shape, size, and I think are important. On the last one there, we know that there's quite strong data that cardiorespiratory fitness, regardless of someone's BMI, is associated with mortality, lessens mortality and morbidity. And we have the physical activity guidelines for Americans. That's worth a read. The executive summary is quite good, actually, and talks about like how to accommodate these exercise recommendations to someone that may have physical disabilities that may limit them from being able to pursue some of these types of exercises. But the multimodal approach of an aerobic exercise program, either moderate intensity or vigorous, and walking's in the moderate one there, where breathing is increased, but you're able to carry on a conversation, 150 minutes a week, some kind of strength training program, ideally twice a week, and mobility exercises to improve balance while reducing sedentary time. This is a normative standard. There's minutes here and goals for that. I try to lessen that like specific, you must get to 150 minutes of exercise a week, and talk more with patients about making small changes of things that they find enjoyable and feasible, asking them, what was it when you were more active that you like to do, and how could we get you back to that? But we know those who follow an exercise program of some type, they're more likely to be of higher cardiorespiratory fitness, and individuals that have higher cardiorespiratory fitness have substantially lower mortality regardless of their baseline BMI. For instance, this study in JAMA in 1999 had patients do an exercise treadmill test for those who did not have disabilities that would make that unfeasible to do, and then measured over time mortality over a 20-year life period. And basically, if you were not in the low fit cardiorespiratory fitness quintile, it doesn't much matter what your BMI was, your mortality risk was much lower than those with low fitness. So again, this is a normative thing. Any statistical, quintiles, there will always be someone in that quintile, of course. And I try not to kind of compare patients to a standard, but helping to explore with patients a feasible activity program is of high priority for me in primary care visits. So just to walk through a couple of clinical conditions, and we'll wrap up here. Hypertension, if I were to ask people the average systolic blood pressure lowering effect of weight loss diets on adults with hypertension at 12 months, would it be 2, 4, 6, 10, or 15 millimeters mercury systolic blood pressure reduction? And I'm not quite sure if people can drop their answers in the chat here, but I'm just going to give the answer here. There's a Cochrane review from 2021 that walks through this. At 12 months, the systolic blood pressure lowering effect is about 4 points. So perhaps lower than some people might expect of the impact of that lifestyle intervention. We know, though, the DASH diet is quite effective at lowering blood pressure. Something you might not know is that the DASH diet trials, which were done at the turn of the century, were intentionally weight neutral dietary programs. The intent was that the baseline weight and the final data point weight was not significantly different, which was the case. These were shorter term trials, I should say, only 8 weeks, but there was not weight loss during these diet plans, and that was by no means their intent to be a calorie reduced diet. The goal of those diets was to increase the amount of fresh fruits and vegetables and grains, things that are higher in minerals such as magnesium and calcium and potassium and fiber and protein, all things that are associated in general with lower blood pressure. And if someone had high blood pressure, the blood pressure lowering effect of those diets is quite significant in this 7 to 12 range, depending on whether some other modifications were added to that DASH diet intervention. So I'm often talking about components of that when I'm talking about blood pressure reduction of someone, again, regardless of their body weight. And as we know, blood pressure drugs are very effective at lowering blood pressure. So the average systolic blood pressure lowering effect from monotherapy of any of our standard blood pressure drug categories. This is a study from 2005, before the era of ARBs, but it has a similar blood pressure lowering effect as ACE and later studies, is in the mid-teen range. So prescribe away as you already are. And when patients are game to do so and their blood pressure is high, and you've decided one of the goals is to lower that blood pressure. For lipids, I just wanted to focus for a moment on LDL. So the average, the average LDL lowering effect of weight loss diets in patients with hyperlipidemia, 2, 5, 10, 20, or 30%. I think I already showed the next slide's answer. You may be surprised to see it's quite modest. Weight loss diets are quite ineffective at lowering LDL cholesterol, more effective, I should say, at lowering triglycerides, for what that's worth. But to counsel someone on using a weight loss diet to lower their LDL cholesterol, I think is not the right approach in general. This is a trial in New England Journal in 1998, where the dietary intervention group, regardless of sex, tend to be quite modest in the LDL lowering effect in the 5% range. Exercise programs do improve that LDL reduction, I should say. There are weight neutral dietary alternatives. The portfolio diet is one example. Essentially, primarily a plant-based diet with increased amounts of legumes, reduced saturated fats, more nuts, things like this. And at least in this, 6-month trial, the LDL lowering effect is higher than that weight loss diet intervention I just discussed, in the 10 to 15% range, and improvements in total cholesterol to HDL ratios as well. And of course, we have our statins. Statins are very effective at lowering LDL cholesterol. If you didn't know the magnitude, I was quite surprised when I first saw this graph. This is from the UpToDate page on hyperlipidemia, for what that's worth. And at the high dose range of most of our statins, the LDL lowering effect, for instance, of atorvastatin at the 80 milligram dose approaches 60%. So when it's indicated to do so based on ASCVD risk or secondary prevention measures or something like this, the statins are the way to go if the goal is to lower the LDL and the patient's up for giving that a try. For diabetes and pre-diabetes, one of the core reasons that it was a grade B instead of moderate evidence of moderate benefit to pursue lifestyle interventions in people with high BMI and the USPSTF was because of the diabetes prevention program trial in New England Journal as a weight loss diet that showed prevention of progression of prediabetes to diabetes. I would say, though, that trial was a combination of a weight loss diet plus an exercise program. There was another study that was also quite large in China in the 1990s called the Daqing IGT and diabetes study. And it took patients with pre-existing prediabetes and randomized them to different lifestyle interventions. There was a hypocaloric diet with the intent for weight loss without a specific weight loss goal. And there was a diet and exercise combined arm, but there's also an exercise arm that had no discussion with patients about weight reduction, and in fact had no change in weight compared at 6 years compared to the control group. And in fact was more effective than the diet and exercise programs at reducing progression from prediabetes to diabetes. So I think it's a compelling case to be made that you could instead focus on finding an exercise program that's feasible. And this in this study, the goal was for patients in the exercise arm to have at least 1 unit a day of these exercise categories. So 1 unit could be 30 minutes of mild intensity, like slow walking, traveling by bus, shopping, house cleaning. Or very strenuous would be 5 minutes only of playing basketball or swimming. So, the goal was to meet 1 unit. And I was surprised in reading this, like how relatively modest. This is not preparing someone for a marathon or something like this. This is something that for many patients, they might find feasible, or at least something striving towards that. That's for prediabetes. For patients with diabetes, there's also strong evidence that exercise programs can reduce blood sugar and assist with glycemic control. This was the DARE study in Annals in 2017. It was a 26-week trial, and it was explicitly a weight neutral intervention, and it had different arms. There's an aerobic exercise program, a strength training program in both compared to a sedentary control. And the baseline A1C was around 7.7%. And A1C reduction was almost 1%, which might be the difference between having to add another medication or not, without any change in weight. So again, the exercise programs, finding something that's enjoyable and feasible for patients is something we should do. Also, there's quite a bit of newer data about the value of counseling people on post-meal walks compared to just clumping your exercise and, for instance, a 30-minute walk randomly throughout the day, not tied to after meals. Post-meal walks can reduce blood sugar significantly more, we think. Particularly in this study in 2016 at the dinner meal, the IAUC is the calculated area under the curve of blood sugar on these continuous glucose monitors that were taken over the weeks of this trial. So there's 2 groups, one that just had a 30-minute walk that wasn't tied to a particular meal, and another group that had a 10-minute walk after each of the main meals of the day, and particularly after the dinner meal, to leave the dinner table after the meal and go on a 10-minute walk seem to be quite effective at lowering blood sugar. So these, some people call these exercise snacks, these short bouts of movement to help, in this instance with glycemic control, can be quite effective. These were weight neutral. That was a weight neutral study as well. And then to close out on one other health condition, to talk about metabolic dysfunction associated steatotic liver disease, the artist formerly known as NAFLD or fatty liver disease or hepatic steatosis, or whatever. There's been many descriptions of this over the years. And this is, I would say, a harder one because we know people who have higher risk MASH or MASLD. Weight control is often part of the treatment recommendations, but the amount of weight control you would need to help someone reduce their fibrosis risk tends to be in the 7 to 10% range, where it's very unlikely that folks pursuing the lifestyle intervention are able to sustain that because body weight's regulated. But I would just like to point out that there was an interesting study a few years ago in New England Journal that looked at people with MASLD and classified them that had a baseline FibroScan, a score of their liver fibrosis. And those in the F0 to 2 range, the low fibrosis group, which, by the way, was the vast majority of people in this trial, 1,200 in that group versus 360 and 160 in the F3 and F4 range. They had much less overall mortality and essentially zero hepatic decompensation events at 10 years. So the liver risks of low fibrosis MASLD are low. And that's been shown in other settings. The main thing as far as mortality and morbidity that people with MASLD suffer from is cardiovascular disease, and addressing those, whether you choose with a patient weight neutral strategies or not, should be the priority, I think. As far as dietary interventions, there's a study in JAMA in 2019. Granted, this was a study of adolescents, but I think is the highest quality study, and other studies in adults that are smaller have shown similar results, that reducing added sugar in the diet from sugar sweetened beverages was quite effective at reducing liver fat, the fat fraction on MRI. These graphs are a bit confusing to understand, but on the left is on the left with the white space and the circles is the low sugar diet, and the line is the baseline, and then the line towards the circle being the post-intervention result. So you see that most of the time in that group, the post-intervention assessment of liver enzymes and fat fraction was lower quite a bit compared to the usual diet. So anyways, quite a bit more effective than a control group or usual diet at lessening fat fraction. So reducing added sugars in the diet, simple carbohydrates, without a focus on weight loss is one approach that could be taken. And then again, exercise, finding an aerobic or resistance training program. There's probably better evidence for strength training than aerobic exercise as far as the reduction in intrahepatic lipids and ALT, for instance. This is a meta-analysis from the Journal of Hepatology in 2007. There's different mechanisms at play that may be complementary as far as why exercise, both aerobic and resistance training, may reduce the risk of progression of MASLD, but is yet another opportunity to explore with patients a weight neutral exercise program strategy that, again, they might find feasible and enjoyable. So to summarize this talk, I think it's important for all clinicians to understand that body weight is regulated, and that's why it's so difficult for patients to achieve weight loss through dietary and lifestyle interventions. Weight bias and stigma is prevalent in healthcare settings and is harmful to patients, leads to poor health outcomes, and we should use strategies in our clinics and healthcare settings to reduce the experience patients have with weight bias, taking a trauma-informed care approach to those folks, with the assumption that most people of a body shape or size or weight that is not within our cultural standards of normality have experienced that weight discrimination either in a healthcare setting or elsewhere, and has carried harmful impacts to their health and well-being. And I think all clinicians should be capable of answering the question, how would you approach this in a patient without obesity? I'll stop there.
Thank you, Dr. Hagen. One question that came up, just to clarify, is just a question about one of your slides. When there was something that said bowls under mobility, underneath Tai Chi.
I tried
was
for
that bowling?
a long time to find what bowls is. I think we're talking about this slide, right? Under mobility.
Yeah.
I have no idea what bowls is.
Maybe
Uh,
it's bocce ball.
that I don't know. I wouldn't be surprised, but yes, I don't know the answer to that. I did try to look that up in the guidelines, and it doesn't actually explain what bowls are.
Okay, other questions? Feel free to put them in the chat, folks. I have a question to ask, which is just if we're asking for permission from folks and we're really taking a weight neutral approach to their healthcare, when do you bring up weight? When do you think it's the clinician's job to bring up somebody's weight?
Yeah, I mean, I think my general approach is that for starts for anyone, I pursue weight neutral strategies to try to protect their health. And when that is limiting our ability to achieve the health goals that they've set with me, for instance, someone with high fibrosis MASLD, or someone with insulin resistant diabetes or things like this, that's when I pivot to having that conversation and try to do that carefully. I would just caveat, I stay away from trying to have those discussions unless a patient really would like to do so at a first visit. I would prefer to establish rapport, find these other weight neutral strategies before launching into that um, discussion. And also when that discussion happens, couching that, and this is a treatment choice, this is an option that we could pursue, such as, weight loss medications or bariatric metabolic surgery, and that we should respect the patient's right and ability to decline that discussion and return to other weight neutral treatment strategies.
Thank you. Just give another minute for folks to type in questions. Okay, here's one. Can you comment on whether or not you think the widespread use of tirzepatide would be a useful intervention for the American public if cost were not an issue?
I don't know. I mean, I think that one of the things you see if you look at the tirzepatide and semaglutide treatment persistence, at a year, those who are prescribed those novel GLP-1s for weight management, it is a much lower proportion of patients who continue those drugs at a year. I'm sure in part due to costs and things like this, but I also suspect the treatment side effects and the kind of more uncontrolled setting outside of a clinical trial is higher. And that we should understand that there are significant side effects that are common with those medications that might make a patient reluctant to continue to take them. I just think this blanket approach, like on the FDA label for those drugs of, BMI 27 to 30 with comorbidities or BMI above 30, i.e. 70% of the adult population or more. I don't think we have good evidence that that broad strokes approach is going to be health promoting long term. I think if you look at more selected cohorts like secondary cardiovascular disease prevention or high risk MASLD or things like this, you will see those benefits, and we can talk with patients about those options. So yeah, this is certainly not going away. There'll be several more drugs, I suspect, in the next couple of years that will be FDA approved. And, in 10 or 15 years, these drugs will be generic and cheaper. So I don't have a pithy response to that.
All right. And then our next question is, so there's evidence of weight impacting osteoarthritis pain and severity. So how do you address that in addition to recommending physical therapy and other conservative measures without discussing weight?
Yeah, I think that's a challenging one. I mean, there's just a trial of semaglutide uh, a couple weeks ago in the England Journal that showed in patients with moderate to severe osteoarthritis that semaglutide reduced overall pain scores And it's not surprising to see in weight-bearing joints that lessening weight is going to lessen that pain. And so, I mean, the first question is like, is the patient where are they at with how their experience with that knee osteoarthritis pain and the pain management strategies that you've already been using, whether that's physical therapy or other treatment options, medications, injections, and so forth. Are they actually eligible for those treatment options anyways? I've seen many times patients who've been counseled like you should take one of these weight loss drugs, and it turns to be the case that their insurance will not pay for that. They're not covered by that. Out of pocket, these drugs are over $1,000 a month. And so I think it's quite harmful to suggest that to patients without first verifying that they're even potentially eligible for those drugs, because it kind of leaves them in a lurch. But yeah, I mean, I think like some of these other scenarios, it's a treatment option. And of course, another option being knee replacement, which we also saw recently is in a trial in JAMA is quite a bit more effective than physical therapy for lessening pain scores for severe OA. Good question.
Thank you. Another question is for Asian folks who need to be screened for diabetes at a BMI greater than 22 because of an elevated risk for visceral fat and epigenetics. How do you approach this in a weight neutral way?
Yeah, I mean, I think, first of all, I have a low threshold to screen any adult for dysglycemia and cholesterol. It's part of my practice to screen everyone at least once every 5 years as adults for diabetes and high cholesterol. There are certain patient populations that are higher risk than others for developing metabolic syndrome at a lower BMI, and populations of Southeast Asian ancestry, that's known to be the case, that a lower BMI can carry the same amount of risk compared to white populations in Europe and America, at least for these health outcomes. So first of all, as far as this question on screening, I screen broadly to anyone, regardless of their health risks, and try to address those health risks with weight neutral approaches that I know to be effective. And then if there's weight management strategies that might be helpful, that's something the patient might be interested in and they're eligible for and so on, I will have those discussions eventually if we're having trouble with weight neutral strategies. Good question.
Thank you. And then I think our last question is, when do you usually have your patients follow up to discuss other options for management? Do you usually wait 3 months or do you use other intervals?
Yeah, I think it depends on what's going on with their health. I have many patients with, there's this concept of metabolically healthy obesity, someone with a BMI of 35 who has no components of metabolic syndrome, no weight-bearing osteoarthritis. My follow-up is an annual appointment. If someone has diabetes and we're using non-weight control strategies, there might be a number of medications I'm using before talking about weight. So it kind of depends on the clinical condition, and the patient, of course, has a choice in that about what they would like to be the follow-up interval. So I think it depends more on their health conditions and generally how I'd manage those, whether I'm choosing weight neutral or weight centric approaches. Yeah, thanks for that question.
Thank you so much for an excellent talk. And actually, one of our audience even put that in the questions just to make sure that you were aware of how much it was appreciated.
Thank you.
All right. Shada, since it's almost 10 o'clock, thoughts on, should we go on to your talk or?